Distinguished guests, colleagues, ladies and gentlemen, you are very welcome to the regional workshop on accelerating AMR action through antimicrobial stewardship in Africa. This is one of 6 regional workshops showcasing best practice amongst pharmacists in antimicrobial stewardship, and we will be culminating these 6 workshops in a global workshop on Tuesday next week. So my name is Sabiha Isak. I am chairperson of the Global Respiratory Infection Partnership, sponsored by an unrestricted educational grant from Reckitt in the United Kingdom. Reckitt has sponsored this pharmacy-led stewardship initiative in partnership with the International Pharmaceutical Federation since 2019. It is my pleasure to introduce my co-presenter, Dr. Mervyn Mpundu, who is the director of React Africa, React standing for Action on Antibiotic Resistance. At React, he is responsible for strategic leadership in implementing React's strategic plan and activities in Africa, focusing on AMR National Action Plan development and implementation, as well as regional strategies. Mervyn is also the Partnerships and Stakeholder Engagement Lead for the International Center for Antimicrobial Resistance Solutions, responsible for Africa, supporting Africa and engagement with countries in Africa, as well as supporting demonstration projects in implementation and intervention research to address AMR. Mervyn, over to you.
Thank you so much. It is my pleasure to provide a brief bio of Professor Sabiha Isak, who is a South African researcher in antibiotic resistance and One Health, and professor in the pharmaceutical sciences at the University of KwaZulu-Natal. Sabiha is also the vice chair of WHO's Strategic and Technical Advisory Group for Antimicrobial Resistance and senior implementation research advisor at the International Center for Antimicrobial Resistance Solutions in Denmark, and a member of the Scientific Advisory Board of the Joint Programming Initiative on AMR. It is our pleasure to have you. Thank you.
So this is the overview of our agenda for today. We will begin by providing a progress on the roadmap that we developed last year. This will be followed by a session on antimicrobial stewardship in action. We will discuss 3 excellent case studies. You as participants will then choose the best AMS case study that will be showcased at the global session on the 30th of November, as I mentioned earlier. So our meeting objectives, Mervyn, over to you.
Yes, the main objectives are to highlight the leadership role of pharmacists in antimicrobial stewardship, in community practice or in hospital practice, but also to drive behavior change and commitment to antimicrobial resistance initiatives through a 3-year AMR roadmap, and to share learnings and best practice from across the region to inform future initiatives in the prevention of antimicrobial resistance. So we do have a roadmap that we have been following for in Africa that is focused really on education, on policy, taking an opportunity for that, and also public health motivation. And really we had broken down the strategic objectives into 3: improving awareness and understanding of AMR, reducing infection through prevention, and that improves sanitation and hygiene, and also optimizing the use of antimicrobial resistance. This, we suggested, would be approached in 6 ways: by mapping undergraduate pharmacy curriculums. Back, Sabiha, sorry. Yeah. I think you went a slide forward. Yeah, great. Then developing pharmacy-specific WA materials that were used this year, and encouraging proper hand washing, and also offering childhood and really focusing on vaccination programs and integrating the aware categorization of antibiotics into formularies, and progressing implementation of the pharmacy-led antimicrobial stewardship programs from hospitals to the primary care health settings. Sabiha? Yeah, go ahead.
No, please, this is your slide. Please go ahead.
Yeah. So the progress that we have made so far, we were trying to encourage proper hand washing and targeting home hygiene and the proper use of the PPE equipment to prevent infections. And so in 2021, we are glad to say that the achievements that we have made include the COVID-19 pandemic that made it necessary and provided an opportunity for actual community pharmacies to be involved in promoting actual hand washing and also in promoting really masking and the prevention of actually COVID. And so the way forward in 2022 and 2023, we shall continue to sustain the momentum that the COVID-19 pandemic has given us and really focusing again on prevention of infections and the WASH programs. The other area is around vaccination, ensuring that we continue to promote really childhood vaccinations and also we shall advocate programs that address the vaccination prevention infections. So such as actually flu, including COVID and others, and these we shall actually expand in the region and hopefully make a lot of progress in 2022 and 2023.
Mervyn, sorry to interrupt. There is a special request from French interpreter to slow down your speed a little bit because she's not able to make to follow you. Thank you very much.
That's okay.
Thank you, Mila. The next one is for me. This is the program, the roadmap progress regarding education and awareness. Our intention was to map undergraduate pharmacy curricula against the WHO competency framework on AMR for health workers. And the second one was to develop pharmacy-specific World Antimicrobial Awareness Week materials with pharmacy associations or regulatory bodies. So in terms of the mapping of the curricula, we have one example from South Africa that Yasmin is going to speak to a little bit later, where there was where a group of academics developed an antimicrobial stewardship curriculum to incorporate into the Bachelor of Pharmacy program. What was very interesting in South Africa also was the fact that our regulatory body, the South African Pharmacy Council, convened a meeting of all of the universities offering pharmacy, and there was a discussion around what types of content should be included in pharmacy curricula in terms of antimicrobial resistance and antimicrobial stewardship in particular. So this work has been published and is available to everybody, and this can be used as an example to extend beyond AMR, to cover all of antimicrobial resistance, and should be developed for all of the other healthcare workers. In terms of developing World Antimicrobial Awareness Week materials, this is WOW Week, and we've already seen so many initiatives, excellent initiatives by pharmacists that have been showcased not only at FIP, but also within the countries and regionally. So ministries of health in most countries either use or adapt the WHO materials, and I think that we should give this a specific pharmacy angle going forward, where our pharmacy associations should really give it a pharmacy flavor and highlight the leadership role that we can play in making sure that antimicrobials are used appropriately in humans and animals, and that antimicrobials are disposed appropriately and such that this environment is safeguarded. Mervyn, over to you.
Yeah, the roadmap progress that we have made in terms of optimizing antimicrobial use is in two ways. The first initiative really focused on WHO's categorization of antibiotics into aware, that's access, watch, and reserve. These are based on the potential for antimicrobial resistance, and the access group has a lower potential and volumes than the watch and the reserve categorization. And stewardship programs are typically focused on the watch group and the reserve categorization. And we wanted to see, are there any countries that have adopted this in their national treatment guidelines or in their stewardship programs. And in 2021, Kenya and Tanzania have adopted the AWARE categorization in their guidelines and also in their national essential medicines lists. In 2022 to 2023, we work with pharmacists, to see that, we actually have more countries adopt this AWARE categorization through working with the ministries of health and also ensuring that the guidelines and the essential medicine list, they actually talk to each other. It is quite common that you'd find that sometimes these documents don't talk to each other, including the hospital formularies. The other one is really progressively implement pharmacy-led antibiotic stewardship programs from hospitals to primary care health facilities. And the achievements here are noted in South Africa. That requires all healthcare facilities to have an AMS program and an IPC program for accreditation by the Office of the Health Compliance and Standards, without which hospitals cannot have, they are unable to operate. And so it's a requirement in South Africa now, and that's a good achievement for us.
Thank you, Murphin. So it's now over to the case studies of good practice from the region. And I would like to introduce Yasmin Khan from South Africa. Yasmin is a young pharmacist with a passion for research and academia. After completing her master's degree and spending a few years lecturing at the Nelson Mandela University, she is now practicing as a ward pharmacist at a hospital in Gauteng. Yasmin, over to you.
Thank you very much for the introduction, and thank you very much for the opportunity to be here with you all today. My name is Yasmin Khan, and today I'm going to be...
Sorry, Yasmin, we can't hear you very clearly. Could you perhaps speak into the microphone a bit closer, or switch off your video so we can hear you better?
Can you hear me now?
Yes, much better. Thank you.
All right. Thank you very much for the introduction, and thank you very much for having me here today with you. Today, I'm going to be presenting a research project which I conducted a few years ago through Nelson Mandela University. The research problem which we aim to address. See the translator.
Yasmin, sorry to interrupt. Can we double check once again your microphone, please? No, it's
audible.
Are you talking via microphone or through your laptop?
I'm talking through earbuds.
Now, can you keep talking, please? Now.
Yes, is it clearer now?
Now is better. Thank you.
Okay. So the research problem which I aim to address revolved around the evolving role of the pharmacist in antimicrobial stewardship in South Africa. We recognize the fact that pharmacists are key role players in stewardship. However, at the time of the study, there was no standardized curriculum for undergraduate pharmacy training in antimicrobial stewardship in South Africa. So the purpose of this study was to develop a curriculum which is suitable for incorporation into undergraduate pharmacy degree programs. The curriculum was developed through a series of study phases. The first of this phase was the content analysis phase. This was quantitative review of literature, focusing both on international and national literature. I see that there are still some who are unable to hear. Just want to confirm if I'm audible.
I now tried to change to the laptop microphone. Is it any better now?
Much better. Can you please keep talking like this?
Is it better?
That's perfect.
Okay, wonderful.
Yasmin,
I'm
please
so
start
sorry
from the
about
beginning.
that.
We didn't
I'll
hear
just
too
start
much.
from the beginning of the methodology, if that's fine.
That's fine. Yeah, please start from the beginning. Thank you.
Okay, thank you so much. I'm sorry about that. So today I'm going to be presenting a research project which I conducted through Nelson Mandela University a couple of years ago. The primary focus of this research project was to overcome the challenge that we were facing in that there was no undergraduate antimicrobial stewardship curricula incorporated in South African schools of pharmacy. And this was a recognized problem since the role of the pharmacist was rapidly developing in South Africa over the past couple of years. So in order to develop this curriculum, a couple of different study phases were carried out, and they utilized a mixed methods methodology. The first study phase was the content analysis phase. This involved a review of national and international literature in order to determine our national policy documents that guide antimicrobial stewardship, and also to gain insight into what studies have been conducted internationally regarding antimicrobial stewardship training at the undergraduate level. From there, we conducted an academic review. This study phase was also quantitative, and it involved a quantitative questionnaire that was disseminated to the schools of pharmacy in South Africa. One nominated participant was nominated by the head of the department to participate in this questionnaire. The questionnaire primarily focused on the degree to which antimicrobial stewardship was being taught at each school of pharmacy at that stage in time. And it also investigated which principles of antimicrobial stewardship these academic pharmacists would recommend to include in the curriculum being developed in the study. The final study phase was the expert consultation phase. This was the qualitative aspect of our study. This study phase involved telephonic, semi-structured interviews, which were conducted with a multidisciplinary panel of antimicrobial stewardship experts. These interviews focused on the perception of these individuals on the role of the pharmacist in antimicrobial stewardship in their hospital setting. And it also highlighted what knowledge and skills these professionals would recommend pharmacists possess when entering into practice in order to equip them effectively for antimicrobial stewardship. The panel that was interviewed included infectious disease specialists, IPC specialists, clinical microbiologists, and pharmacists who had an active role in antimicrobial stewardship and were working both in the public and the private sectors. The collation of results from these study phases allowed for the development of the proposed antimicrobial stewardship curriculum. This curriculum was made freely available to the various schools of pharmacy in South Africa through presentation at national conferences, as well as a publication in the American Journal for Pharmaceutical Education. The final proposed curriculum includes recommendations related to both the structure as well as the content of the curriculum. In terms of structure, recommendations were made regarding the amount of time that the academic should dedicate to the module, as well as recommendations related to assessment techniques and pedagogical techniques. In terms of the content of the curriculum, recommendations were made in terms of the antimicrobial stewardship principles, which should be emphasized when teaching undergraduate pharmacy students. The curriculum was split into several learning units, and the prioritization was also made for specific antimicrobial stewardship principles, which were highlighted as being particularly important for pharmacists through our academic review and expert consultation phase. The key learnings from this study highlighted the fact that there was no existing standardized antimicrobial stewardship curriculum for pharmacy students in South Africa, and the degree to which antimicrobial stewardship was being taught at our various schools of pharmacy varied significantly between the various schools. And this confirmed our suspicion that the preparedness of our pharmacists for antimicrobial stewardship was largely dependent on which school of pharmacy they received their undergraduate training. So it is our hope that this curriculum could serve as a useful tool to ensure that all pharmacists are adequately prepared for their role in antimicrobial stewardship. And it is also our hope that the methodology that was used to develop this curriculum could be a meaningful tool to allow for antimicrobial stewardship curricula to be developed in other regions and also for other healthcare professionals. Thank you very much.
Thank you so much.
Thank you very much, Yasmin. Please, sorry, Mervyn, just to say that please put any questions that you have for Yasmin into the Q&A, and we will take a panel discussion at the end. So over to you, Mervyn.
Thank you so much. Our next presenter is Dr. Tracy Muraya with React Africa. She's Kenyan and works from Kenya as the Senior Policy Officer for React Africa. She is a pharmacist, like I said, who has been enabled to work and specialize in international global health. Over to you, Tracy.
Thank you, Mervyn. I hope you can hear me well. So as we all know, the behavior or how we behave really as adults is something that is inculcated right from childhood. So our intervention aimed at inculcating behavior change within school-going children aged between 10 to 15 years using what we call the Al-4 guide. The Al-4 guide, just a bit of background, was developed through our React Latin America office. And it really just contains different chapters that try to link the association between how we treat our environment, how we behave, and then what then results into good or ill health, and the eventual use of antibiotics, which then translates to antimicrobial resistance or antibiotic resistance if you are talking specifically about antibiotics. So we took this guide and thought to use it and contextualize it within the Kenyan environment or Kenyan context. And we work with students from 4 schools in 2 counties or 2 regions. So 2 of each from each region, and that is Kisumu and Siaya County. So first we had to get in touch with the policymakers, the Ministry of Health at national level, and specifically the AMR Secretariat, because there's nothing as key as really getting the political will and commitment and the blessing to go ahead and involve the population per se, and even eventually be able to be assured of a sustainable intervention or sustainable infrastructure or systems that have actually been put in place through the intervention. So we started at national level, and then and then also engaged at county level, the Ministries of Public Health and Education, as well as the school heads. Then after their blessing, getting their blessing, we went on to identify the schools that our implementing partner works closely with. And these were the 2 schools from each county that were approached. We then trained the teachers and community health assistants to coordinate the project at schools through the health clubs, and also assist at the community level respectively, because we appreciate that the children, yes, while they might be in school most of their time, but then again, they go back home. And what is our aim really? It's not just for the children to develop behavior that promotes reduced use of antibiotics or falling ill, but also just to spread the word and influence back at home or at community level. So then the teachers, having been trained, then trained the children or the health club students on the different Al-4 guide topics. These topics in Latin are lumped into one and termed under the umbrella of Allegra. Allegra, which stands for really the elements that surround us, the air, the water, land, and so on and so forth. So we have used 6 of them, including clean eating and safe eating, and relate them to AMR. So then the community health assistants then assist us when we go back home, especially in building of what we call TP taps. And these are just very simple taps, or rather water dispensing containers made from locally available materials, such as just wooden stick, then connect to a string, and then this is also connected to, let's say, a jerry can, which is opened at a certain specific position to ensure that also the water is not just exposed. And this way then the children are able to learn how to improvise, just using what they have. It doesn't have to be expensive material. And B, through the guidance of the older children, the younger children are also able to look at what is happening. And when they come out of, let's say, using the toilet, then they are able to go ahead and, in fact, they are supervised by the older children to ensure that they do go ahead and wash their hands using the TP taps that are placed in the various stations, either in school or within the community. Actually, this heavily relies on what we call the child-to-child methodology, where the older children are the ones that now teach the younger ones and also ensure that they follow through with what they've been told. Apart from the TP taps, they're taught how to make little small kitchen gardens. And this is also incorporated into, for example, subjects such as home science, which we call that in Kenya. And I know outside there's also either it could be environmental studies or social studies. And in that way, then the children are able to associate healthy nutrition vis-a-vis falling ill at any one time. And that way then they're able to understand that not only do you need to wash your hands, but you also need to eat well so that you don't get ill and you don't continuously use antibiotics or antimicrobials unnecessarily. Then the students use the knowledge gained. We create a fun environment. So they will use songs, they'll develop skits, dances. Just recently during the World Antimicrobial Awareness Week, this week that just ended yesterday, we had art exhibitions and the finalists were actually awarded on how they portrayed their understanding of development of AMR vis-a-vis everything else around them, the environment, the climate, washing of hands, use of toilets, and so on and so forth. They're also able to go ahead and educate their family members and communities at large. We've actually had children coming and telling their parents not to just go use or buy antibiotics or antimalarials for that matter, without a prescription, which we believe is a way forward. So reasons for success, as I mentioned before, buy-in from our policymakers and the school administration, committed teachers, really, really committed teachers, that they are not necessarily paid. They're probably just given lunch or tea during training, yet they really assist us in ensuring that the students are able to grasp the notion of AMR compared to, in comparison with the environment, existing good relations between them and the implementing partner. And then the child-to-child methodology that I spoke about, it actually gives them ownership and a sense of being valued as children. And then, unfortunately, as with any other good intervention, there are threats to the success of the intervention. Just like many other interventions, COVID-related protocols have really interrupted our school going. In Kenya, the schools were closed for 9 months. And then when they opened now, we have been pushed to very short terms, short at times as short as 4 weeks. And so the children are there to learn really the curriculum, but then we are talking of an extracurricular activity right here. So by adopting and adapting the most impactful areas of the Al-Fohad Guide into the national school curriculum, we believe that this will go ahead to be adopted countrywide. Thank you.
Thank you so much, Tracy. Over to you, Sabia.
Thank you very much, Tracy. Resonates very much with the Global Action Plan on Antimicrobial Resistance and starting education very early from school level onwards. So that's really good. And also an AMR sensitive intervention in terms of IPC. So well done to Kenya on that. Our third speaker is Diane Ashiru Oradope, who is the Global AMR Lead for the Commonwealth Pharmacists Association and the Lead Pharmacist for the Antimicrobial Resistance and Healthcare Associated Infections UK Health Security. She's also the Technical Program Lead for the Commonwealth Partnerships for AMS, a UK partnership intervention funded by the UK-aided Fleming Fund to support tackling AMR in 8 African countries. Over to you, Diane.
Thank you very much, and thank you for the opportunity to share a case study from the Commonwealth Partnerships for Antimicrobial Stewardship. CWPAMS, as we often call it, is an international health partnership approach established between the UK and selected countries in Africa. Initially, it was 4 countries: Ghana, Tanzania, Zambia, and Uganda. And then we have now recently extended to 4 additional countries: Nigeria, Malawi, Kenya, and Sierra Leone. We focus on tackling antimicrobial resistance through the use of stewardship. But we all know that to tackle antimicrobial resistance, you need both antimicrobial stewardship and infection prevention and control. So whilst our focus was on antimicrobial stewardship, all the partnerships actually focused also, majority of the partnerships also had infection prevention and control interventions, and I'll share some of those with you. So CPA, which is a global body for pharmacy teams within the Commonwealth countries, was a technical lead. And what our role within that was to connect UK pharmacists with pharmacists in the African countries. And we did that through the National Pharmacy Associations and also antimicrobial resistance committees that they had there. And so once they were connected, we then supported at the programmatic level to support the delivery of the interventions, and to also to reduce duplication of efforts. We supported and we led on a number of initiatives to at a programmatic level. And examples of those were developing an antimicrobial stewardship checklist that institutions could use to assess their stewardship interventions. At that stage, the WHO checklist was not published, so we used an international consensus that was published, and we redid that through a consensus process with our colleagues in Africa before we then deployed that. Since the WHO checklist has been deployed and available, we're now using that in the current program. We also developed an antimicrobial prescribing app. This was from learning from colleagues when they went out, the pharmacy teams, when they went out from the UK to the African countries, highlighting that access to guidelines was challenging. And so we, at a programmatic level, we developed an antimicrobial prescribing app and put the national prescribing standard treatment guidelines onto an app so that it made it easier for clinicians to be able to access the guidelines that were available. And then one of the key parts of this program is that it's the first time where pharmacists have been an essential part of a global health program, and it was mandated that there needed to be a pharmacist both on the UK side and on the African side involved in each of the partnership projects. And the remit of the pharmacist was to ensure that education was delivered. Antimicrobial use surveillance was really key, and we used the global PPS methodology at that stage. It was all the partnerships were multidisciplinary, but pharmacists needed to be part and key within those partnerships. There was a range of travel time spent by UK pharmacists in country, and we also had the opportunity for pharmacists and other members of the team to visit the UK and to work with clinicians here to see how antimicrobial stewardship was run within stewardship committees, but also on clinical wards. It was a 1-year program when the partnerships were deployed, and we were able to have a range of activities and a range of outcomes as a result of that, which I'll share shortly. So I highlighted, so for example, with the app development, not only did we develop and deploy the app, we also assessed the use of the app and the interventions that were possible through the app. And so colleagues in one of the hospitals in Ghana, the Kwalibu team, they were trained as super users, and they supported colleagues to be able to use the app efficiently. And so we assessed the knowledge pre and post or using the app. We also developed a video for local production of hand sanitizers. And this was taking learning from the Zambia partnership, where they had basically taken the WHO hand drop formulation and gone through a process of developing that at scale within the hospital. That became critical for us in UK, and a classic example of bidirectional learning. When COVID hit and we didn't have enough alcohol hand drop within the UK, colleagues that were part of the Zambia partnership were able to locally produce their own hand drop because of the learning they had gained from being part of the partnership. We developed antimicrobial stewardship, knowledge, attitude, and behavior surveys as well that were also deployed through the projects. One of the key extended outputs to this was the leadership development program, initially for colleagues in the UK through the Global Health Fellowship. And so 16 pharmacists, again, the first, were able to go through a leadership development year. They needed to be part of the Global Health Project and travel to Africa, but also got additional training, but also had to were challenged through the year through a range of activities, and we have 16 fellows. We now have, because of that, we've been able to, we've been looking for funding to support pharmacists in Africa, and we believe that we're getting closer to being able to get that funded now, so we can support that leadership development. So far, we have done a scoping review to see the need and what could be part of a leadership program for colleagues in Africa. The key learnings that we've had as a result of this is that the model for UK pharmacists supporting colleagues, or actually co-learning with colleagues in Africa, has strengthened the roles of pharmacists both in the UK and in Africa. The model facilitated bidirectional learning, I've given you the classic example, which became very important during COVID-19. We very much use a train the trainer approach, so that actually we train once and there are opportunities for learning to continue through other teams. And this is really important because we learned that in some institutions that there was a high turnover of staff. There were some barriers to using app, so we identified those barriers. For example, the fact that patients don't necessarily want to see their clinicians in Africa looking at their phone, and they have a different perception, is what we were told. And so we developed posters and a way to help clinicians explain that actually by looking on the phone, they're looking at guidelines, which is better for the patients. One of the challenges that most projects will have is limited funding for scaling up interventions. But what we are really, what we focus on within this program is the sharing of knowledge. So we have so far have more than 14 peer-reviewed publications as a result of the program, both from a programmatic level, but from individual partnerships as well, because we believe by sharing that learning, sharing the evidence, hopefully we'll be able to increase support available. So that's all from me. Thank you very much.
Thank you very, very much, Diane. That's an exceptional multi-country project. I'm going to stop sharing my slide now, and Dr. Mpundu will lead the Q&A. Go ahead, Margaret.
Thank you so much.
Everybody, all the speakers, to please switch on the cameras. Excellent. Thank you so much.
Yeah, so we can see you and direct the questions to the right person. The first question is from Adrian Shepard. I think it's to Jasmine. Do you think that your curriculum understanding gained from South Africa and needs identified could easily transfer across to other countries in developing a broader pharmacy undergraduate program? In other words, I mean, the lessons that you have drawn from your study, are they transferable into other countries? And if they are, would that succeed? Or if there are hindrances, could you elaborate on what the pitfalls could be?
Perfect. Thank you very much for the question. I just want to confirm, can you hear me? I just want to make sure my mic is still working.
Yes, we can. Yeah.
Okay, great. Excellent. So that's a really, really wonderful question. I think if we were to speak to the methodology of the study, remembering that the first phase in the methodology was primarily focused on literature and what has been done thus far, in terms of undergraduate antimicrobial stewardship training. And it also investigated antimicrobial stewardship from an international perspective. So I think aspects of the curriculum that were drawn from that first phase of the study would easily be transferable to other regions and other countries. The problem come in that obviously every country has specific challenges that they face in their healthcare system, different setups that they would prioritize in terms of antimicrobial stewardship programs and teams. So I think it would probably be better if a different region or a different country were trying to implement a curriculum based off of the research that we've done, perhaps even just to do the expert consultation phase of the study. Just that's the phase where interviews were done with a multidisciplinary panel of stewardship experts in practice. And just being able to do that phase would probably highlight if there are any differences and variations that would need to be considered. And then the curriculum could easily be adjusted to be implemented within a different region or country.
Yeah, no, it's really important to do that. Really contextualizing, I think, is important. I mean, getting the buy-in, understanding, your own curriculums and how, we can influence really our educational systems, I think is really critical. There is another question for Tracy. I mean, do you think that there could be a way to follow up on the children program to see if the learned behaviors remain longer terms? I mean, is there a way that we can be able to follow them up and see whether, the learnings and the change in behavior is actually sustained over a period of time?
Thank you for the question. Like with any behavior change, it's not easy. So perhaps it's just following them up, giving them a few months, maybe 3 months, that's a term in Kenya, and then following up the following term and just gauging the children's understanding. Of course, what we are also hoping is that at the end of it all, that whatever comes out as the low-hanging fruits that relate AMR to the different aspects within the school environment or the communities is then also adapted into the school curriculum. Unfortunately, ours is still a national curriculum. Education was not devolved like a health. So then that also comes with its own complications. And I say that because, for example, in the 2 counties we're in, they identify better with sanitation. Sanitation had always been an issue in those 2 counties where there was still open defecation, but now with the public health, that is no longer in existence. So then you'll go to another county where, for example, it's malaria that's an issue, and they might be able to understand that the more you use the antimalarials in an inappropriate manner, then AMR develops faster. So I think the best way is to go after about 3 months, check on them and just keep at it, and especially utilize our community health assistants, because they're always there and they really, they're within the community and they're from the community. Yeah, thank you.
Oh, thank you. Thank you so much. Diane.
May I take
yes,
my
please.
prerogative as co-chair and ask a question? Diane,
yes.
I really, so first of all, congratulations on a multi-country study. And I know that all of the countries are in Africa, but there are always nuances in terms of the context. So did you find something that was similar across all 4 countries, or were there subtle differences that required the interventions to be tailor-made, if you like? So what were the generalizable learnings and what were the country-specific learnings? Over.
Thank you. So I think actually what we found is that in terms of stewardship, the challenges were quite similar. There may be nuances within that, but overall, it was actually, do they have structures and systems in place? So for us, using the antimicrobial stewardship checklist was a really important starting point. And again, as I said, there's this international consensus that was published, which included African countries. But when we came to do the program, we went through a consensus process again and had to change things. So that's one example, because actually they were saying, well, this doesn't work in our context, but we're saying initially it looked like it would be fine because had colleagues from Africa as part of that. So in terms of that, the checklist, but I think also there were differences between institutions. So even within the same country, one of the things that we found quite interesting was that in Uganda, for example, when the partnership started, we were very much a human health focus, but actually in Uganda, they found that they needed to have a One Health approach very quickly. And so they were building on stewardship and building in animal health education and training because of the closeness with animal health and I think that happens in many African countries, but we know particularly across the 4 countries that we're having, the Uganda partnerships really focus more on One Health and community health workers as well. So what I found is that actually across them, the learnings were similar, but institution-wise, there may be differences. So it wasn't about one country is completely different to another. It was really about actually at an institution level, what do they need, and focusing on that. Because for us, we were focusing on institutions rather than country. We did do, before we moved to an extension phase, we did a scoping review again. And in those, we had focus groups across the 8 countries actually this time around. And again, the learnings were quite similar. What we were finding out overall in general, but how you then deliver it might be different.
Just a quick follow-up question, very briefly. I mean, how do other countries benefit? I mean, how is the selection done? And this goes actually to yourself and Tracy. You know, how do you decide where to, which countries and who to support? I mean, how can these folks in other countries where you are not benefit from your programs?
So the first starting point, it's UK aid funding with this through the Fleming Fund. So that was already decided. There are 22 countries, and then within that we were Commonwealth Pharmacy Association. So it needed to be countries that were part of the Commonwealth, so African countries that were part of the Commonwealth, and so we needed to start small. And so the 4 initial countries were those where the TEF had country offices in, or we knew that there had been a need and an engagement and a request. So we go by where there's a request and a need. When we came to the extension period, there were, from the 4 countries, there were some countries that were very vocal about not being included. And so, and there was a great need and a great request. So we go where there is a request and a need. And then we do a scoping and engagement with the national stakeholders to make sure that it is useful. The challenge always is we can't be everywhere, but we are aiming to support. And we've now just been given an opportunity to support the app, the prescribing app, and antimicrobial consumption surveillance across additional 16 countries. So again, we'll be looking to that through the Fleming Fund countries. So some of them, our hands are tied, but again, within that we can expand. But CPA is always trying to support wherever there's a need and a request.
Okay. Tracy, very briefly, we're running out of time.
Okay, so very similar to Diane, exactly what she said, but when it came to this particular project with children, we needed to employ a child-to-child methodology. And so we needed an implementing partner that we can work with who's more experienced, especially when it comes to handling child-to-child methodology. And that was found in Kenya, in the top 2 counties, but it worked very well for us because those 2 counties then had the AMR sensitive aspect of wash and sanitation issues. Yeah, over.
There is a question, the last question that I think that one probably goes to maybe Sabia, myself, and maybe Yasmin can get that one. You know, what measures are we planning, I guess, as FIP, as an African region, on implementing to ensure standardized AMR stewardships will be incorporated in pharmacy schools in our region? Professor Sabia, you want to take a stab at that one?
Maybe Yasmin can speak to the South African context, And
Okay.
then I will speak more, we can speak more broadly in terms
Yes,
of
yeah,
what we're
absolutely.
doing. Yeah, go ahead,
Absolutely.
Yasmin.
Yeah.
Okay, so the curriculum that was developed through our study was made available to the various schools of pharmacy through publications and was also presented at the Academy of Pharmaceutical Sciences conference in South Africa as a means to try to sort of get the word out that this curriculum has been developed. As I think Prof. Essek mentioned, the South African Pharmacy Council has also discussed the importance of including antimicrobial stewardship training at an undergraduate level. So we're moving in the direction of starting to focus on antimicrobial stewardship, but up until this point, there hasn't been any implementation studies to look at the uptake of the curriculum that was developed as part of our study, or whether or not antimicrobial stewardship training has actually been a focus area at each individual school of pharmacy. But I think recognition from the South African Pharmacy Council that it is a focus area is definitely a good step in the right direction, and hopefully is a sign that curricula will start to be implemented.
Thank you, Yasmin.
Thank you.
And more generally, Mervyn, to answer, I mean, the Global Action Plan was published in 2015, but since 2015 until now, there has been implementation guidance and guidelines developed. And amongst that has been the education aspect of it, where there's a competency framework for healthcare workers, as well as a curriculum. Most countries, the first 5 to 10 years, well, 5 years, I would say, of the initial or the first national action plans have expired, and countries are now developing the second iteration or edition 2 or 2.0. And again, all of this, we know far much more now, and we've learned much more from each other's experiences. So what happens now is that the guidance that was developed after the initial Global Action Plan being accepted in 2015 is now available for all of the countries to start using to develop curricula for the different healthcare professionals, to develop school curricula, as Tracy spoke to, and more generally, I suppose, postgraduate curricula or the workplace curricula, as Diane mentioned in her study. So I think, Mervyn, we've had lots of good practice examples, lots of guidelines in the various, for the 5 strategic objectives of the Global Action Plan. And I think that NAPS 2.0 are going to be able to use this, and it'll be far easier to develop interventions going forward. I think we are at the polling, so let me share my screen, Mervyn, and you can
Go ahead.
you can start with the polling aspects of it. One moment, please. Okay, there you go.
So after listening to the panel discussion that has just taken place on the 3 case studies, the first one on antimicrobial stewardship curriculum to incorporate in the South African Bachelor of Pharmacy degree program. Number 2, creating awareness and understanding on AMR among its elementary school kids and their communities, and the Commonwealth Partnerships for Antimicrobial Stewardship program or project that was done in Zambia, Tanzania, and yeah. And the question really is, would like you to vote really following the questions. Which initiative are you most likely to implement in your country out of the 3? Which initiative could you
So can we answer the first question, please?
Before we go to the second one, absolutely.
Yeah, thank you.
Which initiative are you most likely to implement in your country?
So we encourage all 93 attendees to please vote now. Yeah. You have less than 30 seconds, and we want to make sure that everybody votes and everybody's voice is heard. So panelists and presenters, we unfortunately can't weigh in, but we rely on everybody else to do that for us.
And we'll tell you what the prize is after the voting. All right.
Excellent.
Case study number 1, 53%, case study number 2, 31%, and case study 3, 17%. So there we have it. Number 1 is case study 1. The next question, the second one, is which initiative could be implemented the quickest in your country? If you look at the 3, again, case studies on stewardship, on raising awareness, and on engaging the pharmacists and really strengthen the pharmaceutical systems, which one would be implemented the quickest in your country? Again, you can select one. Presenters can't vote. And we encourage you actually to go forward and implement some of these in your countries. The last one, oh no, let's look at the results. Case study number 2 has it at 45%. That's creating awareness and understanding of AMR among children and their communities. All right, the last one is which initiative do you think would have the biggest impact in your country? Which initiative do you think would have the biggest impact in your country and probably would be a catalyst for more action on stewardship, on WASH, on IPC? There we have it. Case number 1, AMS curriculum to incorporate in the pharmacy degree programs in the region. So the winner certainly is case study number 1, and they will be showcased at the global session on November 30th. Would like though to congratulate all the presenters for these nice and excellent presentation in different areas as we try to achieve the objectives that we set at the start of the year. Over to you, Sabiha.
Congratulations, Yasmin. Your case study goes up to the global event on the 30th of November. I'm particularly pleased because it's from South Africa. No bias. So as I mentioned earlier, this is one of 6 regional workshops. The best case study from each region will be showcased next week. So please register for the session on the FIP website. The 30th of November event is also quite unique, where we are holding a debate amongst global experts on AMR, and they will be debating on whether pharmacists are protagonists or antagonists of AMR, using illustrative examples of good and bad pharmacy practice. So going forward, the FIP AMR Commission, set up by the FIP Bureau in 2020, will monitor the progress on AMS roadmaps annually, stimulating the global community of pharmacists to be an active agent in minimizing AMR. So this has been an event that has been jointly undertaken by FIP, the Global Respiratory Infection Partnership, and Reckitt in the UK. I would ask one of our hosts to please put in the chat the website for GRIP, where there are several resources and materials that can be used. And we are really grateful to Reckitt for the support for this initiative over the years. So with that, I would like to thank every one of our presenters. They were outstanding presentations, some exceptional work being done on the African continent. I'd like to thank all of the participants. Thank you for staying for this period, and thank you for your contributions in the Q&A as well as in the chat. We really appreciate that. A special thank you to the people behind the scenes, Mila, Carola, the interpreters, and all the people that are working behind the scenes at FIP, at Cello, and at Reckitt. Thank you very much for making this event a success. And we will see you we've got 3 regional sessions tomorrow, so you're very welcome to attend. But we definitely will see you on the 30th, where the debate format promises to be something special. So thank you very, very much for attending, and have a great day further.
Thank you. Bye.
Bye.
Thank you. Bye.
Thank you. Bye-bye.